Hi, everybody. I'm Andrea Sato. I work on adult programs here at Wilton Library, and I welcome you here today. Thanks for coming. And we're so pleased to partner again with RVNAhealth. We're trying to increase our number of health-related programs here because we know it's important to you. Just before I turn it over to Kate Campbell, our first speaker, I'd like to just let you know about a couple things coming up. On Wednesday this week, from 11 to 4, we have a Red Cross blood drive. So the American Red Cross is here all day, pretty much. Thursday morning, if you know anyone with small kids in special ed, there is a talk on reasonable accommodations for special education children in school. And Thursday night, we have an author talk by Terrence Hawkins called The Rage of Achilles. So this author has reimagined the Iliad on how it actually took place. So with that, I will not delay any longer, and I'll turn it over to Kate Campbell, and your speakers will introduce themselves. Thanks.
Good morning. How are you? Thank you so much for having me. I am Dr. Kate Campbell. I'm a physical therapist, but I work with RVNAhealth, and RVNAhealth has a multitude of services. One part of us includes an outpatient clinic where I see Parkinson's patients almost on a daily basis, and a Parkinson's center that has a lot of resources for people with Parkinson's, their care partners, and their medical team in the community. We'll talk a little bit about that. But today is Intro to PD. If you were back in college, I would call this the 101 course, where it is all the information. And the feedback I get from this is like, whoa, it's a lot of information, but I swear I'm just skimming the surface. It's tons of topics, and it's because of what happens in the brain and how it affects many systems in your body. So we have to talk about all of those symptoms, but we're not going to go in depth. This is just, again, the overview. So you're going to walk out thinking, holy cow, this is a lot of information. That's okay. You don't have to retain all of the details, just to know that, oh, I remember back in 2024, Kate talked about this symptom that I might experience. This is related. Don't have a freak out and go search WebMD for the answers, right? So can I just get a raise of hands who has Parkinson's? Who is here on behalf of someone they know that has Parkinson's? Great, I think that covers everybody. Is anyone else like a senior care advocate or looking for other resources? No, we have like either got it or a direct correlation. Awesome, now I know who I'm talking to. So what is Parkinson's disease? It is a neurodegenerative disorder, meaning it affects part of the brain, specifically the part of the brain that produces dopamine. Dopamine is a hormone, a neurotransmitter. It is known as the happy chemical. It makes us feel good. It is produced when we feel good, and it also travels to another part of the brain to help control movement. So that's why some of the first symptoms you might notice are movement-related things. Also interesting, some people lose their sense of smell way early on and think, oh, that's just COVID, or oh, it's just my nose going. And that is truly some of the first signs. Another one is constipation, that you're like, I guess this is just how I am now. Nope, it's Parkinson's. But then it takes a long time for you to find other symptoms that you think, this is really weird. I need to see my primary care or a neurologist or even a movement disorder specialist. So I do want to spend some time talking about the dopamine, because everything else we talk about is back related to the dopamine and what it does. So in terms of a hormone and a neurotransmitter and what it makes you feel emotionally, mentally in the brain, is it's a reward system. So it is released in response to pleasurable experiences, such as food, happy social interactions, sex, and it reinforces when you have that burst of dopamine, oh, you want to do it again. I know I have a golfer in the audience, so am I. Anyone else golf? Why do we do this? Why do we chase this little ball down in 18 holes? I don't know, because most of them are bad shots. But if you've ever had that one shot, oh, Lisa, you won't like this. But sometimes I get that one shot, I'm like, I'm going to quit my day job. LPGA, I got this all the way. That's dopamine. That one shot that makes you want to come back, that was your dopamine release, and oh, it feels so good. So when you don't have dopamine, sometimes it's hard to feel happy. Sometimes it's hard, and that can lead into those other symptoms we'll talk about, depression, anxiety. But in terms of movement, dopamine involves the regulation of the basal ganglia, which is a structure deep in the brain that coordinates your movement. And when the dopamine levels are low, like in Parkinson's, it can lead to these motor symptoms such as tremor, stiffness, and difficulty with movement. So some people, tremor is their first symptom, and that's what they go and get checked out for. It could be in the hand, it could be in the leg, and it is usually at rest, and then it stops when you think about it or stops when you go do something because you're using your brain. It's important to note that you and Parkinson's are two different people. You have your conscious brain, and we have been living with our bodies and walking and talking since we were 1 year old. In fact, I often can pick up a child and pick up the grocery bag and walk, and all I have to do is think about the walking or the yelling, come on kids, let's go. I don't have to think about my steps. I don't have to think about heel toe, because that part of the brain is doing it for me because of dopamine. And when you don't have the dopamine, the regular automatic parts of movement degrade. So it might turn into shuffling. It might turn into a hard time turning or hard time hitting a target with your hand or bringing a fork to your mouth. But then when you say, I know how to do this, I've been doing it forever, let me think about it, it's actually great. So one of the tests I see, do you have Parkinson's, yes or no, is I watch someone walk while they're talking to me. What'd you have for breakfast? I had cereal and fruit. Okay, stop. Can you take some big steps for me? Do all these things is in you, but when you have to do two things at once, which we call dual task, it looks like you don't have that ability. I also want you to think, you have Parkinson's. You aren't Parkinson's. This is just one more thing on your medical chart. Someone's got osteoporosis. Doesn't define you. You just got to manage it. Someone's got high blood pressure, cholesterol problems, diabetes. It is just another thing to manage, and you can manage it once you understand what's going on. So how is it diagnosed? Of course, the people raising your hands have already been diagnosed, but I get a lot of people that I see some symptoms and say, you got to get checked out. Sometimes it's the primary care will say, something's not right. Go check out a neurologist. So usually it's the neurologist or movement disorder specialist that does the diagnosing. Neurologists are good. Movement disorder specialists are better. In fact, with just their physical exam, just watching your walking, coordination, strength test, how you move, they are 80% accurate at diagnosing Parkinson's on the first visit. And if they're not sure, come back a second time, and that percentage goes up to 90%. So I do recommend, if you haven't had an official diagnosis and you don't have a movement disorder specialist on your medical team, go seek one out. And if you start looking for one now, it might be 6 months to a year wait list. They are super popular here in the area. If they need further testing, this has been evolving with all the medical technology coming around. One is the medical history, the physical exam. Sometimes if they're not sure, they're like, let's just give you dopamine and see what happens. So the dopamine comes in the form of levodopa, carbidopa, and they will start with medication. If you respond, there's your answer. You didn't have dopamine, I gave you dopamine, you're better. Go ahead, live your life. And if you need more scans where they need to look at the brain, there are PET scans. They've now been replaced by DAT scans, D-A-T, which is a dopamine transmitter uptake. So it's looking at literally dopamine in the brain. They've even developed, thanks to Michael J. Fox Foundation, some further blood tests and skin biopsies, because long story short, there's these proteins that fold over, and that's what causes the brain to not make dopamine, blah, 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 blah. But those proteins are all over your body, including your skin. So they lay you on an exam table, they numb the area with an injection, they take a little puncture, and they send it off to a lab in Texas. Why don't they do this all the time? It's very expensive. So maybe someday blood tests for Parkinson's will be part of our annual exam, because if we can catch it sooner, we can manage it sooner, right? So symptoms, we have motor and non-motor symptoms, and I'm sure we're all more familiar with our motor symptoms. Because the dopamine's not talking, is not there to talk to the basal ganglion, we don't have automatic smooth movement. So for example, if I say 1, 2, 3, go, it might take a little while to get going. Or vice versa, time to stop. It might turn into a bad stop signal. Bradykinesia means slowed movements. Slowed movements might turn into slow walking, slow reaching, slow getting dressed, slow speaking. It doesn't mean the brain is any slower, it's just the output of the muscles is slower. Rigidity, where if I try to move an arm, I get this like cogwheel effect, and it might make you feel stiff. Like, oh, I have arthritis in every joint of my body. It's just so hard to move my body. Resting tremor is a clinical hallmark of Parkinson's, not intention tremor. So if you're only shaking when you go to get the glass or when you're drinking or it's a really heavy pitcher, that is not classic Parkinson's. It could develop into that, but usually it's the pill rolling hand tremor. And festinating gait is that shuffling or that freezing. Did anyone watch that show Shrinking on Apple TV? Oh, well, you love Harrison Ford, right? Who knew that he was the comedic relief? He's usually like Indiana Jones, right? So he is a psychiatrist, and he is now dealing with a new diagnosis of Parkinson's, and he gets all stressed out. His daughter and him are having a fight, and he goes to try and slam the door in her face, and he freezes because he's stressed, because he's thinking about the fight, not thinking about his walk. In the moment, it's funny. I guess it's not really funny. But if you want to see what it's like to kind of live with it, he does a really great job, and it's a very funny, uplifting show. All right. Postural instability means losing your balance or falls, which we know comes later. So it's not just because of the walking that falls happen, it's because of the posture, the being unaware, and a classic one in one of the tests is the pullback test, where we pull your shoulders, and do you catch yourself, yes or no? Often I can tell someone, I'm gonna pull you backwards, do whatever you can to catch yourself, and they have no awareness that they're going over, and I have to catch them. Then there's the non-motor. Because of the dopamine in the brain, it affects all sorts of brain functions. So some of them are cognition, how you're thinking. It is not usually the first sign, it is later in life, but cognition does change, and we'll see signs of dementia. It is not Alzheimer's dementia, it is Parkinson's dementia. Because of the lack of dopamine, that happy hormone, we get anxiety, apathy. Apathy is like I just don't feel like doing that today. I know I love it, but I just don't feel like going to see the grandkids today. That's kind of apathy. Depression is definitely part of it, and sometimes depression is social, so you're psychosocial, and sometimes it is truly chemical. This is one of those things that it is chemical, it is in your brain, it is hard because you're not getting enough of that dopamine. Sensory changes, some people have pain. It's not the biggest thing, but sometimes you get tingling and burning because it is a nerve symptom. Unaware of how your body is moving. Autonomic changes are the things that happen in our body that we don't have to think about. No one has to think about processing food in their stomach through their bowels to then have a BM, right? That happens automatically. Those autonomic systems slow down because they are two muscles. And that's why constipation tends to be one of the first symptoms. Sleep disorders. We'll talk about that later. It is very common to have sleep disorders. Any questions so far? We will have Q&A later, but again, this is so much information, and it's just a small group. Raise your hand, talk to me. Let's talk about things if you have any questions there. So that's the very quick, I swear, overview of the motor and non-motor symptoms. Now let's talk about how different disciplines on the medical team can help you. So I am a physical therapist by trade, and what a physical therapist does is takes an assessment from head to toe with usually how you're moving, your mobility, how you're walking, what does your balance look like. We'll talk about that in a little bit, your strength, your flexibility, posture, endurance, and we're always trying to relate it, well, what do you want to do in life? What do you need to accomplish, and how is your body able or not able to meet those needs? And then we make a plan based on what we see. We say, oh, well, here's weakness, let's strengthen. Here's slowness, let's speed it up. Here's balance issues, let's figure out why. And it's important to note that we have different tests to figure out more precisely what is the issue, which helps us target the exercise prescription. So even as a doctor of physical therapy, I cannot prescribe meds. I prescribe exercise, and we are the experts in exercise science. Who has seen a physical therapist? Has your physical therapist been LSVT certified? Oh, you cannot leave this room without knowing what LSVT is. I can't wait to teach you. Balance. Balance is one of the issues, that postural instability. But what is balance? R.I.P. the Queen. I've had this picture for so long because it is just the perfect picture of good balance. So here she is, walking down the stairs, looking lovely, waving at the crowd, but looking somewhere else, carrying her handbag, walking downstairs, and somehow not falling. That is balance. It's not necessarily, can you stand on one foot? Sure, that's important. We'll talk about that later. But balance is the ability to remain upright even while you're moving, and to see clearly, to know where gravity is without having to look at it and stay stable. This is the complicated version. It's to show you that balance is complicated. I'll take you through it a little bit. Pretty much there's 3 systems that tell our brain the information it needs to decide if you're in balance or not, or what to do about it. First is vision. We see the world. I see that wall, and my brain is assuming that gravity is coming from up there. And if I'm seeing the ceiling, I must be thinking, I think I'm falling backwards. Or if I'm seeing the floor, my brain is saying, you're falling forward. You should do something about that. You should take a step, right? If you're ever in a dark room and you don't have the vision, you are using other senses, and if they're not working, you could fall. So we always try to recommend night lights in the right area so that it's not casting shadows. Or you ever get stuck in your sweater and now you're blinded just for that split second and you lose your balance? It's because you were using your vision to help stabilize you, and now it's not there for you. So, but there's plenty of blind people that walk around and don't fall down, right? Thank goodness we've evolved to have 3 systems. Number 2 is proprioception. This is a fancy word for the ability to know where your joints are in space. So you're walking along and you're about to roll your ankle. My joint is telling my brain, watch out, it's going. You should do something about that, right? Or to know, there's pressure in my toes. I might be falling forward. There's pressure in my heels, or more on my right, left. The skin, the joints, the ankles, feet, knees all give input to the brain so it can make decisions about where you are and what you should do about it. So when I rehabilitate people with total joints, total hips, total knees, the last thing is we have to learn proprioception again, because now you don't have your knee joint and that cartilage to talk to you anymore. It's metal and plastic. So your brain has to realize, oh, there's other things I can listen to more. And we are amazing human beings and creatures that can adapt. The brain is always learning no matter what age. You just have to give it the right exposure. The last one is the more complicated one, the vestibular system. If you've ever had vertigo, you know how important your vestibular system is, where the world is spinning. It's these structures in the inner ear, way, way, way in there, that have fluid and crystals. I like to think of it as a rain stick. If I tilt the rain stick this way, it all comes down. And you can hear it because there's these little hairs that the crystals and the fluid will hit. Well, when the hairs go one way, the brain knows I must be moving that way, or the other way, or backwards, or rotation. You know your vestibular system is working if you're in an elevator and you know which way you're going. You could tell if you're going up or down, right? But your vision didn't change, the wall's the same. Your foot pressure didn't change, the floor didn't change. It's because of the vestibular system that senses the gravity change and the movement of your head in space, left, right, up, down, rotation, and it tells your brain, oh, that's where I'm going. So all three of them have to work to have excellent balance. But if you're losing one, thank goodness you have two more. If you lose two, you're okay. You just gotta work at it, and you don't want to get stuck in your sweater. That's all I need for you to take from this, that balance is complicated, and our job is to sort through what type of system is not working well so we can rehabilitate balance the best. Walking is another motor symptom that degrades with Parkinson's because of that slow movement. And even if you're thoughtful about your steps, sometimes it's still slow. So they did a really interesting study. They called walking the sixth vital sign. Any nurses or medical in here? You know your vital signs? Anyone been to the doctor recently and checked out your vital signs? Come on, give me some vital signs. What are they? Blood pressure, pulse, respiration, go ahead. Temperature? No. Yes. That's the blood oxygen. Yep, pulse ox, blood pressure, heart rate, respiration rate, and temperature. There's our 5. So they found that actually the speed at which you walk is very much indicative of the state of your health. And those who aren't walking fast, they maybe can't go home if they went to the hospital. So they measure this. And what they found is, and by the way, this is not miles per hour, this is meters per second, that those who are slower need more help in life, ADLs, activities of daily living, more likely to be hospitalized if something were to happen, more likely to fall, maybe limited to the house or the community. Like, I just go to doctor's appointments, that's it. Someone else has to do groceries for me. Or they can function well. So 1.0. 1.0 is about this speed. It's not terribly fast. There's a lot of people that don't walk this fast. When you walk 1.0 meters per second, all the good things happen. You're independent with everything you need to do in the home. You're less likely to be hospitalized if something were to happen to you, a fall or an illness. You don't need physical therapy to keep you healthy. You're more likely to go home if you went to the hospital. You function well in the community, and at 1.2 or so, you can even go to New York City, cross the street, and a taxi won't hit you, right? So walking speed is important, and what physical therapy needs to do is help you find the right way. If you were leaving this room thinking, I think I'm a little slow, I'm gonna try what Kate said. I just want you to think about taking big steps. You don't have to think heel toe, you don't have to think about stretching your legs, just think about taking big steps and see, because those big steps will change into fast speed. I do not want you to think that this is fast, right? Just turn it into nice big steps and let the arm swing. And if you're going to walk for exercise, take some time to not think about what's going on or where you are or the beautiful snow. Think about your steps and get ingrained how to walk fast. If you're a care partner and you see your partner walking a little slow, say, stop right there. You can make it. 10 steps. Ready, go. And you're just turning their conscious brain on to focus on their steps, and lo and behold, it usually improves. You have a bad back. Ugh. It definitely depends on what the bad back is. You're right, with stenosis, with you standing up tall and taking big steps, it could aggravate the stenosis. When I treat stenosis, though, walking is part of the protocol. And it's this balance of turning on symptoms, turning off symptoms, turning on, turning off, or doing some exercises before. If it's sciatica, you got to take care of the back first. Yes, this is always in the ideal world. But if there's something else complicating that you can't do what you're supposed to do, that's where an expert can come in and help sort those things out for you. Does that help a little? I know. I wish I could just fix it for you. So the other thing I really want you to walk out of this room knowing is that for Parkinson's, you need to exercise. And a general, easy stroll is probably not enough. So first I'm going to mention why it's so important. So this doctor, Alskog, is a movement disorder specialist at the Mayo Clinic. And he went through all of the literature about exercise and Parkinson's and put it together in a couple series of articles. And what he was really looking for is there a connection between exercise and cognitive decline? And is there a connection between exercise and the motor symptoms that later on, even with medicine, it doesn't have a response? So let's see. Exercise and cardiovascular fitness has been proven to correlate to the progression of Parkinson's. In fact, in some animal studies, it's shown that these neurotrophic hormones that are released with exercise can have a neuroprotective effect on the brain. We're protecting neurons from the toxins that it's exposed to. It also enhances neuroplasticity, which is a fancy word for the ability of the brain and our nervous system to change, grow, learn, literally increase its white matter brain size. So over time, with the right exercise, which we'll talk about, you can increase its ability to learn, to have new connections, and build new neurons. It needs to have, our brains can also actually get physically bigger in volume when we're performing aerobic type exercise. And aerobic means you gotta be huffing and puffing a little bit. If you put it on a scale of 0 to 10, 0 is I'm sleeping, that's not hard. 10 is I'm crossing the line at a marathon and I can't wait to collapse. It's somewhere in the 6, 7, 8 range. If you're pushing that much, you should have to take a breath every sentence or so. You shouldn't be able to go on for paragraphs and paragraphs about what's going on in your life. Then you're not working hard enough. Another interesting revelation is it doesn't matter when you started. You don't have to be an athlete in high school or college to get the effects. You can start midlife and still get these neuroprotective effects for your brain. And those who don't have Parkinson's, those who exercise even starting in midlife will have protection from the disease. So in conclusion, medication, which is either dopamine or helping dopamine, is only fixing the dopamine problem and the symptoms. It is not stopping the progression of the disease, but exercise does. Exercise is the only thing. If you have a chance at reversing, improving your function, slowing down the progression, or if you don't have it yet, preventing it, exercise is the best thing you can do. Yes, I'm going to give you the Parkinson's exercise prescription. In fact, let's go there. So the benefits of exercise: improving your walking, your flexibility. Actually, cognition improves, as we discussed. Attention, concentration, coordination, endurance, and sleep. To think, oh, I'm so tired and now I have to exercise. No, exercise actually gives you more energy. Maybe not right after your 30-minute bout, but overall you will have more energy, less falls, less freezing of gait, less depression, anxiety, because it is protective. The APDA, American Parkinson's Disease Association, and the American College of Sports Medicine came together to say, we know exercise is important. Parkinson says, we know exercise is important, but what specifically? So this graphic is available. You can take a picture. It's available on the APDA website if you look up exercise recommendations, and it's 4 main categories: aerobic, strength, balance, agility, multitasking, and stretching. I'm going to make it a little bigger for you here. The idea is aerobic exercise, again, that 6, 7, 8 effort level for about 30 minutes, at least 3 days a week, is important. And that could be walking, swimming, biking, elliptical, pickleball, boxing, what else? Dance. Just get your heart rate up, but not like because you're stressed and mad, because you're actually moving your body. Yes. Strength training, yes. The brain can always learn. It might be a little slower, it might take a little longer to get the effect, but it is never too late to exercise. And what might be my moderate intensity aerobic might be too hard if he or she is doing whatever they can do, even if it's sitting chair yoga, and it gets the heart rate up to that moderate intensity, that is helpful, not hindering. So there's always something. And at the end of this, if you feel like, I get it, Kate, this is important, I have no idea where to start, that's where a physical therapist might come in to help find the right strategy for you. Yes. Micrographia is small handwriting, which is associated with Parkinson's, because everything becomes slower and smaller and quieter. And so we have to target it. It's all motor symptoms. We have to target it with the right exercise, the right cueing, the right words, just like the walking gets slower and smaller. So we have to say big steps. And with handwriting, we say big letters. And with our voice, we say really loud. And the Parkinson's brain thinks it's doing great. It thinks it's doing whatever is normal, but it's actually too small. So we want to recalibrate the brain to say, what you think is too big is actually right on target. What you think is too loud is actually appropriate. So go ahead, scream at me. It's good. Go ahead, swing those arms. What you feel is this is actually just fine. Instead of the robot arms, right? Like this. Yeah, so it doesn't matter what time in life, it doesn't matter when the diagnosis is, there's always something to accomplish with exercise. Strengthening is really important. When people go to the gym, they just did a recent study that you go and work out, you think you're doing great, you're picking about 30% of your maximum weight, but you really need 50, 60, 70, 80% of your weight, maximum weight. So let's pretend you can lift a 10-pound dumbbell. You'll go and lift 3 pounds, a lot. And you'll stop at 10 because someone said 10 is the right number. Well, really, that should be 5 or 6 or 7 pounds. And it should be a struggle to get to number 10, right? So strength training 2 to 3 days a week. It'll probably take about 30 minutes, and you're looking for those big muscles. You're looking for squats, so you can work your legs, and you're working arms and core and back and butt. But make sure the intensity is there, that you are lifting more than you think. You're stronger than you think, I promise. Balance and agility needs to be practiced. If you don't use it, you lose it. So this could be a program a therapist gives you, or things like yoga, tai chi, where you're doing a lot of balance, static and dynamic. So standing still is one way, right? But being able to move in these balanced positions is also important. And that's just yoga and tai chi are great ways, lots of research showing that they improve. And stretching, because of the rigidity that comes with the disease, it's important to maintain that muscle length. Maybe there's a back problem and now things are getting tight. So just spending time stretching. To me, this sounds like you have to be exercising every day, all day long to get all of this. You don't. I'm a very busy mom and I like the 2-for-1 special. So if I can find something that does 2 things for one, I'm in the right place. So yoga might take care of the balance, agility, and the strength training and the stretching. And tai chi might be the balance, And an exercise class like boxing might be the aerobic, the strength, the balance, the agility. And if they add some stretching at the end, that's good. Dance would be aerobic and balance, agility, multitasking. You see how you can do a bunch of categories with one type of program? So what I would do is I would look at my week, look at the exercises that you like to do, and see where they check off. Another exercise program that's super important to Parkinson's is LSVT. LSVT Loud, it stands for the Lee Silverman Voice Treatment, came about because this patient was talking very slow and quietly. And so a speech therapist said, well, let's try loud. Let's try exercises that Susan will talk about later, and I'll let Susan do that. But then the physical therapists were jealous and be like, you're just dealing with muscles. We deal with muscles too. Let's make big movements. So there's a protocol of 7 movements. If anyone's done it, you'll be very familiar with these. There's a certain way to sit to stand. There's turning around. And it definitely works on all of the elements. It is strengthening and balance, multitasking and agility. It is aerobic and it's stretching. When you do the program for the first time, ideally, it's 4 times a week for 4 weeks. Sometimes that just doesn't fit into our lives, so we do it twice a week. But the idea is it is like medicine. Because of its intensity and amplitude focus, it actually increases dopamine in the brain, like medicine. So the idea is you do it every day to get that burst of dopamine and remind yourself, today I'm gonna move big. So that when you're done, you walk big to the kitchen and you walk big to the car and you hit a really big, nice golf shot, right? So it's specific to Parkinson's with a lot of research behind it. If you have Parkinson's, if I did, I would be doing these exercises every day because of all the research behind it and how it coordinates with your exercise prescription and what's going on in your brain. Okay, so I don't have to harp on this. I hope you go out and exercise, but if you need any help, find a physical therapist that can help you get started, considering there's back pain, considering osteoporosis, considering this recent heart thing that I had going on, considering I've never exercised before. I don't know what it's supposed to feel like. That's where we can come in and just help you start slow and go to your goals. And it's really important that exercise is salient. Salience means that it's important to you so that you know why you're doing this stupid squat. So you could pick up your groceries and put it in the cabinet. Why am I doing step-ups? So you could carry your groceries up the stairs or your grandchild off the floor, right? So if it's important to you, you actually get more of a dopamine hit during your exercise. Any questions there? So with all of that, what can you do? Get exercising. It's never too late. It doesn't matter what age. It doesn't matter when you were diagnosed. It doesn't matter what stage of the disease you're in. If you had to take away something right now, I wrote down a couple balance exercises, standing on one foot, walking with head turns. Because I'm using my vestibular system at the same time, standing with your feet together, eyes closed, because when the eyes are closed, we're training the vestibular system. And if I had to say go for a walk, being very aware of what you're doing with the walk. Walk big steps, big arms, and big posture. Okay, so this is where I would sit down and I would have the social worker come and talk about more of the non-motor symptoms related to Parkinson's because of the dopamine in the brain. That's like the main mantra here, right? So we know that there's the non-motor symptoms, memory, cognition, emotional changes, and it just means that you might have to adapt life. I had a patient the other day, I said, you can't just sit down and take a nap. Do you want to help cook? And his wife says, yeah. So what I do is I get the pepper out and I get the knife out and I get the cutting board and I tell him to do this and he has to stand and do it. So maybe he's not saying, I'm gonna make this meal from scratch. What do I need? That might be too complicated, but to do something even with what's going on in the brain. So we want to have this balance of like, I love you so much. I see you struggling. I want to help. But sometimes you help by making them do. You just got to set the stage in the right environment so that they can be successful. Other memory and cognition strategies, maybe it's using a calendar or reminders for the medication. There's some devices that dispense the medication with a big alarm at the right time. And also prioritizing yourself, self-care, and recognizing when you need help. That's what social workers are all about. The other thing, I've heard just some horror stories that early on, like you here are doing great because you're here and you're not thinking about the end of life. But I gotta tell you, my life's gonna end too. It's happening to all of us, not just Parkinson's. Have those hard conversations. I know they're hard, and if you need help, that's what social workers are for. But have the conversation about who is the power of attorney if something were to ever happen, healthcare proxy, and I love our social workers develop the 5 wishes. Have an answer to these conversations. I had one daughter who said, it was so nice that mom wrote down exactly what she wanted to wear in the funeral, because then me and my sister didn't have to fight about it. It was just there. And that was a gift because all they would do is fight. So having those conversations are really important. And if you don't want to do that alone, that's what social workers are for. So the other thing, because of anxiety, depression, apathy, care partners, you didn't sign on for this. Like, I'll love you and marry you and in richer or poorer in sickness and health, but no one chose Parkinson's, right? But here you are. Here's the sickness and in health. You need support too. So people with Parkinson's, you need support. Maybe a support group's for you, maybe it's not. I suggest just trying it, but also care partners to come and talk and have other peers to support you through your journey with your Parkinson's care partner. Okay. I think we need to get up, right? I've been talking for way too long. So we're going to do a test. If you are not good at balance, would you just stand behind a chair? And if you're good, just come stand in front of your chair. Yes, we don't need to get up. I know. Okay. Here's the test. How long can you stand on one foot? Let's all pick our right foot. The chair's there if you need it. On your mark, get set, go. That's the answer. I want you to try. Good. Yes, so that's another one. If someone can do this for 30 seconds, and I'll have them close their eyes. Let's see what happens. Good. Okay. Other leg. We're going to time it this time. On your mark, get set, go. 1, 2, 3, 4, 5, 25, 27, 28. You're still going. Close your eyes. Wow, look at you go. Nice job. Open up. Okay, how'd you do? If you did not get 10 seconds, isn't this scary? 84% chance of death over the next 7 years. So how about standing on one foot every time you're at the microwave? Every time you're brushing your teeth, get this good so that you have a nice longevity. But here you can measure your age and gender against how many seconds you got. So just take a mental note. How'd you do? Who's above their average? Nice, nice, bravo. Okay, next one. Because of that smooth movement, turning around is often difficult. So watch me. Turn around in a circle. On your mark, get set, go. 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Good, just one circle. And go go the other way, go. 1, 1,000, 2, 1,000, 3, 1,004. Good. So, if you're, usually 4 seconds is my cutoff. So you definitely don't want to be above 5.7. Often with Parkinson's later, I'll see lots of little steps, so we're counting the steps. Ideally, it's like a quarter turn. Quarter turn, 2 steps, 3, 4, 5, 6, 7, 8. So we're looking for 8 steps or less. And if you did less than 4 seconds or less than 4 steps, you're in good shape. All right, have a seat. Okay, stand up. Good practice. We're going to do that as many times as possible. For now, I'm going to get my timer. I will do the time. You do the number. Arms crossed if you can. That's the perfect test. If you need your hands, that's okay too. On your mark, get set, go. 1, 2. Count yourself. You're halfway there. Woo, hope you're getting your heart rate up. Come on, we got 5 seconds. 3, 2, and time. Woo! How'd you do? Check your age, check your gender. Those who are in the less than on the left are a higher fall risk, and average, not exceptional, average is on the right. So maybe think about where you are and think about where you want to be. All right, for the sake of time, I'm going to skip the nurses and occupational therapists. If for some reason we have time, we'll come back. All right, I'm going to introduce Susan DiGregorio. She's our speech and language pathologist or speech therapist, and she works at our outpatient clinic as well as in the home. Come on up. I gotta grab my tea.
Hi, everybody. As Kate said, I'm Susan. I'm the speech pathologist that works with RVNA. I see people in their homes, and I see people in the outpatient clinic, not just people with Parkinson's. I work with a whole host of disorders, people who have stroke, people who have brain injury. I happen to see a lot of Parkinson's. There are a lot of people diagnosed with Parkinson's in our area, and we are so happy to have the Parkinson's Center where everyone can come together and meet other people that are going through the same thing and have access to just all of the supports and the therapies that we offer, because education is so, so important to living your best life with this disease. So I came today because I wanted to make sure that everybody is aware of the potential changes in their speech, their swallowing, their language, and their cognition because of Parkinson's. Not everybody experiences these symptoms when they're first diagnosed. Sometimes it's the first symptom and you don't even recognize it as such. It could be years prior to actually getting your formal diagnosis. Sometimes it is much later in the disease process. But if we're individuals here with Parkinson's, or if we've known other people with Parkinson's, you probably are recognizing some of these changes. So again, what a speech therapist will assess will be your speech, your voice, your swallowing, your cognition, and your language. Now, these changes have a direct effect on your quality of life. So you might not always be going to the doctor and saying, first thing, I'm talking more quietly. That's going to be put on the back burner because maybe you're having more falls, and that's the priority. but then your doctor won't know to refer you to a speech therapist. So it is important that you're really aware of these changes, even though they might be very subtle in the beginning, so you can mention them to your neurologist, or you can go to your doctor and say, hey, I want to go see a speech therapist. I'm noticing some changes, and I want to see what could be done about that. Okay, so how does Parkinson's disease affect your speech? Well, there is a motor speech disorder. So this is a motor symptom of Parkinson's that most people with Parkinson's will develop the type of motor speech disorder called dysarthria, and in particular, hypokinetic dysarthria. Now, we have a lot of fancy terms for other types of dysarthrias, but the one primarily diagnosed in Parkinson's is hypokinetic. And it's characterized by having a very quiet voice, a weaker sounding voice, sometimes a lot of hoarseness when you're speaking, having perceived slurred speech. Sometimes people will try to talk really fast to get everything out, and the sounds can run together. So trying to think about people that you know with Parkinson's or how you're talking, and thinking, are these some things that I'm noticing about myself? The first thing we always ask is, well, what are people telling you? Are they asking you to repeat often? Does your wife or your loved one always say, I can't hear you? And the answer I always get is, well, they don't have their hearing aids in. Nobody can hear me because they can't hear. And yes, I know that that's true. A lot of people have difficulty hearing, but you do have to be aware, just as Kate was saying, where your brain is not getting the feedback when you're walking. It doesn't recognize maybe that you're taking smaller steps so that you're not swinging your arms. The same thing with the speech. Unfortunately, the sensory feedback loop is being disrupted. So you're not getting that feedback that you're talking really quietly, and the noise in the room has gone up, and now the person that you're talking with can't hear you, but you haven't adjusted your volume at all. Okay? That is the major complaint that I get. Unfortunately, with the changes in the brain, it's affecting the movement, right? The movement of the muscles when you're walking, but also the movement of the breathing muscles, the diaphragm, the lungs, the voice box, the larynx over here. All of these structures need to work in harmony in order to produce enough volume to speak. And if those are rigid and then they're not moving well enough, you're not going to get that louder voice. It's going to be very, very effortful to speak. But a speech therapist can really help you work on that. Examples of how to work on it? Is that what you mean? Oh, yes, we're going to go into that, okay? Okay. So what we want to get somebody to do is, first of all, to recognize that it's not just that the person they're talking with maybe doesn't have their hearing aids in. It's that Parkinson's is affecting how the respiratory effort and support you have to produce this speech. Okay? So we have to get into your brain, talk louder. Okay, so just like Kate had mentioned, that recalibration, this does not happen overnight, okay? This is a change in the way that you are doing something that you've done since you were 2 years old. Now, all of a sudden, you have to be very mindful of how loudly you're talking and how clearly you're talking, and looking at the other people and saying, are they hearing me? Are they understanding me? And how can I adjust? Some very, very simple strategies are, one, to talk louder, to speak in some shorter sentences or phrases. If you truly feel like you cannot finish that sentence, don't try to push it out into the very, very end, because the voice has become a whisper, or it sounds very strained to us. And we're going to have to ask you to repeat anyway. So you went through all that trouble, and now you got to go through it again. Look at the person you are talking to before you speak. So I do home care. I've been in lots of homes. I see how people operate. It's very similar to me and my husband, right? He's in one room, I'm in the other, the TV's on, our daughter's making noise, and he says a whole sentence, and what do I say? What? And he has to repeat the whole thing over again. Okay, so if you truly want someone to hear you, get their attention first. Have them turn the sync off first. Have them put down what they're doing. Let them pick up their heads. Let them look right at you. Then you can start talking. Conserve your energy when the person is looking at you. You make sure you're in a quiet environment, and you set yourself up for success. It's just common sense, right? But do we do it? No. But we're here to make life easier, right? So sometimes we have to take those extra steps to make things easier. Plan conversations and appointments, if possible, for when you have more energy, okay? Think loud. So we spoke first, talk loud. We're also getting you to think loud. These are the cues, the very simple directions that we just tried to drive home. Think loud. You're not going to be shouting at me. I always get that feedback too. I don't want my grandkids to think I'm shouting at them. Don't worry, they're not going to. The tone of your voice is still going to be happy and pleasant. It's not going to be a scary voice. Your grandkids are not going to be afraid. You're going to be projecting your voice, and it's going to be more normalized, okay? Because you think that you're up here, but you're truly down there. If you think loud, you're going to normalize to be right in the middle. So coming to a speech therapist, we can do the assessments. We look at your speech. We also take into account how your speech is affecting you in your daily life, okay? And we want to know, what is it stopping you from doing? Are you having phone conversations less? Are you going to visit friends less? Because guess what? All of those things, those are going to have a really bad impact on your cognition and your mental well-being, okay? We're here for the whole picture. I'm a speech therapist, but I don't just care about your speech. I care about the whole picture. I want you to succeed as much as you can in all areas, so we want to address as many areas as we can. So Kate began talking about LSVT big, but as she mentioned, it started with the speech pathologists. So I'm going to take our credit here because we are a much newer discipline, so we're not around as long as physical therapy, but this is something that started with us. It has 30 years of experience. It is a highly evidence-based therapy, okay? So it's a standardized treatment. It's customized to you and your goals. The focus is increased loudness. When someone talks louder, they automatically will talk slower. It's very hard to do both, to talk loud and talk fast at the same time. You just can't formulate the words that quickly. So there's the improved articulation. There's the improved clarity of your speech. We try to teach better intonation, the prosody of speech and language. How can I change my intonation during my talking so that I don't sound like a robot? Improved facial expression as well. So sometimes people might be saying to you, well, you always look mad now, or I can't tell if you're joking because you have maybe like what they call a frozen face with Parkinson's. There's a reduction in movement of the facial expressions. Coming to speech therapy and explicitly addressing these things, again, it builds awareness, and it can get you to say, hey, I need to pay attention to this. How can I practice this every day and work on my facial expressions and my loudness? Okay, so I also want to address swallowing with Parkinson's disease. Again, it might not be something that your neurologist has brought up to you. You may not have a problem with swallowing. I mean, I evaluate people all the time. They look at me like I have two heads. No, I'm eating perfectly fine. Okay, that is wonderful. Just monitor it, okay? And as soon as you're starting to notice that there are some changes, go to a speech therapist or go to your doctor first and see if you can get in order to see a speech therapist or have a swallowing evaluation done, okay? And we're going to talk now about some of those signs that you should monitor. Coughing or choking, a lot of throat clearing also when you eat or drink. Those are immediate red flags, of course. Everyone does it every once in a while. Okay, so I don't want to alarm you and think every single time you cough, something must be wrong now. But keep an eye on that and try to track, is this getting more often? Is this happening more often now, almost every day or every meal? Is the person's voice sounding wet or like there's a frog stuck in their throat? Does the person need a lot of swallows to just even get the food down? They feel like it's stuck over here. Do they have food left in their mouth after they're chewing and swallowing? Do they have almost like a freezing up? Now, these are some signs that can happen much later in the disease process, okay? Sometimes there's weakness with the muscle of the lips, so food can come out, or a lot of people will also be sitting with their mouth open, and they're not realizing that they're doing this. And that's a biggie because we get a lot of people with complaints of drooling. But if you're sitting with your mouth open, and you're not swallowing as often enough, where is the saliva going to go? So you have to draw your attention again to your mouth, sit with your mouth closed, breathe through your nose. Some signs that you may have had what we call an aspiration event, which is food or liquid going down the wrong pipe. If you start to develop any chest congestion, fever, chills, lethargy, a change in status, maybe that big coughing event that you had at dinner just the other night the food went into the lungs and is developing into a pneumonia, okay? So even if this is not affecting you now, it's something to definitely keep an eye on and be aware of that it could potentially happen because it could develop into a pneumonia and send you to the hospital, okay? So some very basic, without an evaluation, some very basic things that you can all do starting today. Focus on your eating, right? Pay attention to what you're doing. Try to avoid distractions or make sure you're not talking with food in your mouth. Take small bites and small sips, right? Go one small bite, one small sip at a time. Chew and swallow. Chew well enough. Don't just take two little quick chews and then it's down the hatch. I sit, I chew, I'm the last one done every day, but it's fine. Like I'm okay with that because I know what can happen if you're not chewing your food well enough. For each bite or sip, it's okay to take 2 swallows to make sure it gets down okay. If you're feeling at all that food is getting stuck in your throat, this might be just the very basic, easy strategy for you. Swallow twice. You should also be mindful of taking a sip and then swallowing at least twice before you start talking, okay? Just because it's gone from your mouth doesn't mean it made its way all the way down or that all of it went down with that first swallow. I get a lot of complaints of people having difficulty with their pills. So I have difficulty swallowing pills as well. Make sure that your pill is placed in the right spot of your tongue. Make sure it's placed in the right direction. Try to take it with some applesauce or whatever pudding you have around the house. That will help it glide down better. Make sure your mouth isn't dry before taking your pills. If you need to, you can switch to liquid versions of your pills as well. Okay? Okay, but ultimately, having a swallow study, so there's clinical evaluations, which is what I could do with you in the office, but I don't have x-ray vision. So in order to see what is actually happening when you're swallowing, going for what we call a modified barium swallow test, which is done by a speech pathologist and a radiologist. It's a very not invasive procedure. It's done right at a radiology suite at the hospital. That is one of the best ways to figure out where something is happening that it's affecting the swallow, and then what could we do about it? Because there could be other strategies aside from the very basic general techniques that everybody should be doing now. There could be specific exercises. If we've identified where there's a weakness or a change in your swallowing, we can decide on what exercise would be best to address it. Another type of swallow study is an endoscopy. So that is a little bit more invasive. It's not painful. It's uncomfortable though. You're putting a camera through your nose, letting it hang down right over here, and then eating and drinking at the same time. And we're looking to see, did anything get down the wrong pipe? Because the pipes are right next to each other. Okay, and one of them has to be closed so the other one can open. And the airway is the one that's always open. So if you swallowed, or if you didn't swallow and something went down there, it's going into the wrong pipe. Okay. Well, your body reacts by coughing. So don't hold back those coughs. If you feel a cough coming on, don't hold it in because you might be embarrassed. Your body is doing what it's supposed to do, okay? And now, of course, when in later stages of disease, when coughing is so impacted and somebody cannot generate a really strong cough, that does become a problem. And a lot of diet modification has to be put into place to avoid those instances from happening in the first place. Okay. So the next topic that speech covers is cognition. So unfortunately, people with Parkinson's are at a higher risk of developing dementia. And dementia is just an umbrella term for a change in cognition that is severe enough to affect your day-to-day functioning. Okay? Mild cognitive impairment will also occur in about 20 to 50% of people with Parkinson's. People with mild cognitive impairment can still live on their own, go about their daily routines, but there's definitely some more pattern-like behaviors developing, some more forgetting, some more difficulty with planning and executive function skills. And those are the higher level cognitive skills that allow us to, let's say, plan a trip, get tickets, plan out an itinerary, get money in order, schedule our transportation there, all those steps that involve lots and lots of organizing and cognitive processes. Those are our executive function skills. Those become affected in mild cognitive impairment and, of course, dementia. There are neurochemical changes. So there's changes in the brain in the signaling of neurotransmitters. I don't want to get too involved in it for the sake of time and for the this type of talk, but the changes that we see are in memory, attention, processing, and mood. Okay, so again, just to go in a little bit more, slower thinking, information processing, right? How do we take in the information from our senses and what do we do with that information? Okay, so long-term memory is a very different thing from short-term memory. So long-term memory will be saved, will be retained in mostly every neurological disease. The short-term memory, the ability to process and encode and store and then retrieve new information, that's what we're talking about here, okay? So if you have Parkinson's and you're starting to notice some changes with this, now might be a good time to go to a therapist or go to your neurologist and mention this and say, can I have some more testing? Can we develop a baseline and I can know what can I do about this? There might be medications, but it's not a one-stop shop, right, with Parkinson's. With anything really, there's a lot of factors. There's a lot of disciplines and a lot of therapies that we want to try. So speech therapy, cognitive therapy could be one of those that could be beneficial for you, because you might also be having difficulty focusing your attention and multitasking. Maybe you can no longer work. You've had to take a shorter work day now because of these. We talked about the working memory and short-term memory and executive function. We also notice a change with visual spatial functioning. So motor planning and navigating your way in a new environment, those are also very much affected. And we also want to touch upon the language too, right? So difficulty finding the words that you want to say and losing your train of thought while talking. Again, these will lead to a change in the quality of your life, social isolation, avoidance behaviors, depression, and what happens next, further cognitive decline. Okay, so it becomes a nasty cycle then. So we want to try to break that cycle, get the education, get the strategies in place so that, even though you may be experiencing more gradual changes, you're at least knowing that you're doing the best that you can to stave off a more significant dementia. Okay, so it is really important for you to stimulate your brain every day. Okay, having conversations, but also trying to challenge yourself. Okay, so the brain loves to learn new things. Just as Kate mentioned before, the brain does not stop learning. Take advantage of this fact. Learn something new all the time. Join a new class. Try to learn a new language. Learn a new song if you're a musician. What is interesting to you? Now is the time to pick up something new and say, I know this is hard, but the outcome doesn't really matter. It's the process. It's you working your brain every day on something that is cognitively challenging and not just staying in your comfort zone. And of course, we're dealing with a whole continuum of severity here. So depending on how severely impaired the patient might be, or the person with Parkinson's might be with their dementia, just even something as simple as going through picture albums and stimulating conversation about things in the past, right? Using words and language that you haven't used in a long time. These are all really important. So the speech pathologist completes a cognitive linguistic evaluation. We go over how it's impacting you in your daily life. We collaborate to develop meaningful and functional goals for you. And we talk about a treatment program or a plan, things that you could be doing at home, okay? And it really can't be done alone. It's really good for you to have some support and to reach out to support groups and to have the places like the Parkinson Center where you can go and know that, hey, other people are going through this too. I'm not the only one that's having some memory issues or can't find the words that I want to say. Other people have this too, and let me see what they've done maybe that has helped them as well. Okay. We're going to move on to sleep hygiene now. Kate, did we want to do that slide, or do we want to, for the sake of time, go into another area? Okay, so Monica's going to become... Okay, so I'm going to be introducing Monica now. She is our nutritionist. Let me just get to her. Okay, perfect. Yeah, excellent. So thank you guys so much. I'm so happy to have you, a very, very good audience here, and we'll be here for question and answer after.
Hi, everybody. How are you? My name is Monica Marcello. I am the registered dietitian nutritionist at RVNAhealth. So I am the primary nutrition educator, and a lot of my role is seeing clients one-on-one to support them in their individualized nutritional needs. I primarily work with digestive disorders, but also have worked with quite a few people with heart disease, high cholesterol, Parkinson's, of course, obesity, weight management, children nutrition, family nutrition, the list goes on and on. So today I want to, of course, highlight the role of nutrition without Parkinson's. Our CEO loves to say this quote, and I kind of copied it from her. I have to give her credit, but she says, there's not a single disease or condition that can't be helped or prevented, or in some case even treated by food and nutrition. And of course, Parkinson's is one of them. So just really quickly, is anybody familiar with what have you heard about the role of nutrition and Parkinson's disease? Well, I'm seeing some people shake their heads, right? I don't think it's talked about quite enough, primarily because physical therapy, occupational and speech therapy are the main treatment methods for Parkinson's, but there is in fact quite a bit of research on nutrition and Parkinson's. So the bad news, it's bad news, good news situation. Bad news is there is no diet that has been shown at this time to treat Parkinson's. The good news is there are diet and diet patterns that have been shown to slow down the progression of the disease and also delay the onset of the disease. So what you have here is a pretty intricate graphic, but really what this highlights is the diet, the Mediterranean diet, which is almost that gold standard diet for Parkinson's disease and many neurological conditions. And it sort of shows why this diet is so beneficial. And one of the main mechanisms of why this diet is so beneficial to delay the onset, delay the onset of Parkinson's, but also delay the progression, is because of the role of these nutrients in the gut. So unlike Las Vegas, what happens in the gut does not stay in the gut. So all the foods that we eat then go to every single cell in our body and, of course, our brain. And what this graphic sort of highlights is over here on the blue side, you can see that a Mediterranean diet, and we'll dive into what that actually is, I promise. But you can see what that is it's high amounts of omega-3s, polyphenols, which comes from our fruits and vegetables. The omega-3s comes from our chia seeds and our salmon and our tuna. Dietary fibers, that comes from our whole grains, our oats, again, our fruits and vegetables. And you can really see how it starts working in the gut. So by eating the omega-3s, polyphenols, and dietary fibers, all part of the Mediterranean diet, we sort of have this change in bacteria in our gut. And we start to produce healthy bacteria. That sounds kind of counterintuitive, but I promise you, there is bacteria in our gut that can be incredibly beneficial to our overall health if we're feeding it properly. And then what happens is that bacteria actually produces, so it's almost like that bacteria digests our digestive products, and create something called short-chain fatty acids. These are then compounds that go from the gut into the blood, right? I said what happens in the gut does not stay in the gut. It goes into the blood where it can then go to our cells and, of course, our brain. And you can see that it has this sort of antioxidant properties. And what this antioxidant properties are they actually minimize cell death that occurs from something called reactive oxygen species. So over time, but especially when we've got stress, injury, diseases, conditions, inflammation, we have a buildup of these free reactive oxygen species. And the antioxidants that are produced, or that we consume rather, and then sort of get into our blood, actually scavenge them and take them away from inducing more inflammation, tissue injury, and cell death. And then you can see sort of on the purple side that if we have what's, traditionally the SAD diet, standard American diet, you can see that we've got, that's typically full with high saturated fats, dietary fibers, that can increase harmful bacteria. And when we've got this sort of dysbiosis, right, more harmful bacteria than good bacteria, well, the body's still doing the same thing. It's going to produce some short-chain fatty acids, not nearly enough to then go into the blood and body and brain to really have that antioxidant, anti-inflammatory effect. But it can also let some inflammatory compounds into the body, which of course can exacerbate inflammation. So this is just a graphic really to show you, if this was not already on your radar, how important not only our diet is for slowing the progression of Parkinson's disease, but the relationship between the gut and the brain and the body with Parkinson's disease. Now, a little bit more on gut health. There's some more new research and almost a theory among some scientists that does Parkinson's originate in the gut? And the reason that they are speculating this is because people with Parkinson's, well, first of all, everybody here has trillions and trillions, up to 3 to 5 pounds of bacteria in your colon. That's a fact. We cannot live without this bacteria. They cannot live without us. Now, everyone here has their own individual microbiome. So no two people, even if you're twins, are going to have the same exact microbiome. But what they recognized was that people with Parkinson's had different microbial patterns, so different patterns of these bacteria and microorganisms than the rest of the population or people without Parkinson's. And so it really got them theorizing, again, because remember, what happens in the gut affects the rest of the body. It got them theorizing that this could potentially be a way not only to help treat or delay, but also for us to early identify who might be more susceptible to Parkinson's disease later in life. And again, you can also see here that within somebody with Parkinson's disease, by many complex pathways, that you can actually be more susceptible to pain. In Parkinson's disease, it's upwards of 70% of people have constipation and reduced GI motility. So the constipation sort of happens second to reduced GI motility, which just basically means how well are things moving through you, right? So if things aren't going to be moving through your stomach, to your small intestine, to your large intestine, to the toilet, we're going to be more prone to constipation. And of course, you've got increased GI disturbances in Parkinson's disease. And now, again, what's happening in that gut certainly can increase pain, depression, anxiety, behavioral changes, and a lot of it is because of that dysbiosis, that ratio of bad bacteria to good bacteria. So a little bit more about Parkinson's and gut health is that, again, Parkinson's affects all over the GI tract. We just had Susan talking about how it affects your swallowing, right? And your mouth and your esophagus, that is certainly part of your GI tract. But the three areas I really wanted to focus on here was one, the colon, right? The colon is the large intestine. So people with Parkinson's are more prone to constipation. Not only is that just flat out uncomfortable, that could also affect your medicine, carbidopa, levodopa, absorption. Additionally, prolonged constipation is going to further exacerbate that bad bacteria, good bacteria ratio. Additionally, it affects the stomach, right? Delayed gastric emptying. So if you have delayed gastric emptying, you're going to be more prone to bloating, again, more discomfort. And not only is this going to affect the medicine absorption, it's also going to affect the absorption of vitamins, minerals, and antioxidants. If we can't get those antioxidants absorbed, which absorption primarily happens in the small intestine, not the stomach. So if things are staying in our stomach for too long, right, we're going to have higher rates of inflammation. And then this is an interesting one, small intestinal bacterial overgrowth. This is a fairly new diagnosis, I would say about 20 years or so. And this is becoming more and more prominent in people with Parkinson's as a result of the delayed gastric emptying. What happens is your bacteria, whether it's good or bad, that's supposed to live in your colon, works its way up into the small intestine and creates a lot of inflammation in that small intestine, which again can not only affect the rate of absorption of your medication, but the absorption of basic nutrients, antioxidants, vitamins, and minerals. So speaking of medication absorption, the first thing, and this is specifically carbidopa, levodopa. Now, the first thing, of course, that we want to do is check in with ourselves. Has our frequency of which we go to the bathroom, has that changed? Has the consistency of which we go to the bathroom, has that changed? I know you didn't expect to hear about poop today, but it's an important part of the physiology. So if you've got really small, hard pebbles, and that's become your new norm, that's sort of one way that you can understand, okay, my body might not be optimizing absorption of vitamins, minerals, antioxidants, and this medication as well. Now, in addition to taking a look at the overall, am I bloated? Am I having GI signs and symptoms? Am I constipated? Another way that you want to optimize the levodopa absorption is by timing it with your protein. So protein intake, again, quickly think, eggs, some, dairy, milk, cheese, of course, your meats, your fish, some of your nuts and seeds, right? Tofu, tempeh, these foods all have protein. Now, protein and carbidopa, levodopa are actually compete for each other for absorption in the small intestine. So you want to space out your medication with your protein intake. So the easiest way to do this is by taking the medication 30 minutes before you eat, primarily on an empty stomach. You could also certainly work with a dietitian, right, who can sort of time your meals to ensure that if you need to take it with food because it otherwise makes you too nauseous or you just don't feel good, that we're just making sure we've got reduced protein during that meal. Now, just to circle back again with how having these GI disturbances can cause medication absorption, right? So sometimes what's interesting, and I actually learned this on a webinar, that some people say, the medication's not working, and so they're getting more and more medication, but really the problem is the absorption. The problem is the health of the gastrointestinal tract. And once we fix that and also ensure adequate timing of the medication, we now need way less, and we're seeing the health benefits as a result. So I've talked a lot about a few different things. To sort of take it back so you can think about this a little bit more clearly, the first thing that we want to do is understand the relationship between the gut and Parkinson's disease, and that what happens in your gut does not stay in your gut. So anything you eat or drink, for better or worse, is going to go into the blood, the body, and then the brain. We want to adhere as best as we can to a Mediterranean diet, and even though the Mediterranean diet, or no diet for this matter, has been shown to treat Parkinson's disease, we do have some solid research that states that it significantly can delay the progression of the disease. Now, the Mediterranean diet has lots of antioxidants, omega-3 fatty acids, and fibers, and that's what primarily makes this diet so beneficial. So to talk about a little bit more, what are these things? So again, whole grain foods, that could be oatmeal, that could be barley, that could be quinoa, that could even be a whole grain bread, even though I will say the best whole grains are those that are unprocessed. And even your freshest whole grain bread is gonna have a little bit of processing. So those are gonna contain your fibers as well as your antioxidants. Oils, again, the Mediterranean diet's a little bit different in that it really encourages a higher fat diet, getting lots of healthy fats from extra virgin olive oil, avocado oil, as well as avocados, nuts and seeds. These are going to contain fibers and, again, antioxidants. Additionally, fruits and vegetables, of course. Anytime you think of fruits and vegetables, they can almost be synonymous with these antioxidants and anti-inflammatory properties. There's not a single fruits or vegetable that are off limits. However, there are some fruits or vegetables that have been more widely studied. And those include raspberries, strawberries, blueberries, garlic, and onion, as some of the most studied in Parkinson's. Additionally, we already mentioned nuts and legumes, but really increasing those to 1 to 3 times a day. Again, that's where your antioxidants, your fibers are going to be. And then for your omega-3 fatty acids, those are primarily going to be in your fish, salmon, tuna, herring, mackerel, sardines. I usually recommend omega-3 fatty acid fish about 2 to 3 times a week. And then really reducing really reducing red meat, butters, added sugars, and then every now and then having your dairy and your poultry. But again, you're not emphasizing those. So for example, in our culture, it's very common right now to have charcuterie boards where you've got different meats and cheeses. And so it's not that we need to eliminate cheese, certainly in the Mediterranean diet, but perhaps you're making a quinoa salad with beans and you've topped it with a fish and you've got different vegetables in it, and then maybe you put a little goat cheese for that flavor, right? That's very different than having a big board filled with multiple different cheeses. Or another example would be like a grilled cheese. cheese. So versus doing a grilled cheese, which is common in our, in the American diet, again, going back to that salad with like a little bit of cheese to give it that flavor. Additionally, I thought that this would be interesting. I just wanted to highlight in a research study what foods that they found were associated with delayed Parkinson's progression. It was, again, of course, to no surprise, fruits, vegetables, nuts, seeds, fish, olive oil, herbs, and spices. And what foods were associated with an increased risk of Parkinson's progression. Not going to surprise anyone except for one thing. So diet soda, non-diet soda, right? We're not probably too shocked there. Canned fruits and vegetables were actually associated with increased risk of Parkinson's disease progression. Beef, ice cream, and yogurt and cheese in abundance. Now, to circle back to the canned fruits and vegetables, I believe that this is probably due to the amount of added sugar or added sodium that was accompanied with these fruits and vegetables, not necessarily because they were canned themselves. So if you only have access to canned fruits and vegetables, please don't let this deter you. Any sort of fruits and vegetables, beans as well, canned are going to be better than none. Okay, so please don't let that deter you, but I did think it was an important piece of information. So again, what can you do now? So of course, if as best as you can, aim to eat whole grain pasta, brown rice, wild rice. Think things with color. The deeper the color, the more antioxidants or the richer the antioxidants are going to be. Sweet potatoes, regular potatoes, barley, peas, fruits. Like I said, the top's going to be berries. Things that are purple, that bright color, figs, grape, cherries, vegetables, your leafy greens, as well as those onions and garlic, your cruciferous vegetables like cauliflower, Brussels sprouts, broccoli. Protein, really, really sticking to that fish, the omega-3 fatty acids, fish for about 3 times a week, and then supplementing that with your lean proteins such as chicken, turkey, or pork. And then, of course, beans as an excellent source of protein. And then really thinking high fat. So the avocado oils, nuts and nuts butter. And then of course, consider your protein timing. So at a bare minimum, just take your medication 30 minutes before a meal. Okay, so with that, and also what I do just want to say, if you suspect that you're having constipation, your stomach doesn't feel right, I strongly, strongly recommend you work with a dietitian for 2 reasons. One is because we first want to, minimize what potentially could be irritating you. But additionally, there's an abundance of specific foods and nutrients and dietary patterns that can reduce the intestinal inflammation, that can make that dysbiotic gut microbiome be something that's very plentiful with this good bacteria. Dietitian can help with constipation, nutrient absorption. So please don't hesitate to reach out to an expert in this space if you suspect that there might be something going on with your stomach. So thank you guys for being a good audience.
All right. Is this on? All right, we're gonna sit for about 10 minutes and just have a question and answer. I am always hungry after Monica talks, and hopefully I go and feed myself with some healthy things. So yes, there was so much information. Like I said, Monica could have given a whole talk for an hour, and Susan for a whole hour, and I probably could have done 3, and we have programs that do that. So continue to look us up on rvnahealth.org/Parkinson Center for our events, because we do go into deeper conversations, but we'll take your questions now.